Hi everyone, welcome. We're just waiting for a few more people to join and then we'll get started. In the meantime, if you just want to pop a little message in the chat to share where you're coming from today, where you're joining from, and just anything about you and your role. Great seeing a few more people join. Great to have you here this afternoon. Oh, welcome, Lisa. Nice to have some of you join us for the afternoon, even if you couldn't make it for the morning sessions. Hope everyone else is joining from a sunny space as well. It's lovely here. Cool, we'll give it a couple more minutes just to see who else is going to join us. Also, you said you can't hear me. Hopefully others can. Yeah, it looks like everyone else can. Oh, lovely, Alan. 5 minutes walk from the North Sea. Beautiful. Perfect. Great. Hope all of you also have had some lunch and some energy and sustenance, and we can avoid the notorious afternoon slump. Great. So we've got nearly 55 of us today. So I think I'm going to kick off and start. So thank you everyone for joining. It's great to see so many of you join us today. I'm seeing a few familiar names and faces, but actually quite a few names as well. So for those of you I haven't met yet, I'm Zarina and I'm the Innovation and Collaboration Manager in the Q team. I'm joined by my colleague Joe Scott, who's the Q Insight Manager, and we'll be doing a top and tail double-headed sort of approach to chairing today. We hope you've all been enjoying the morning sessions if you've joined them, and that the sessions have been really energizing and thought-provoking. So just to give you a quick run through of how we'll be using the technology today, I know a few of you have already joined the sessions this morning, but for those of you who are joining for the first time, subtitles are available if you click on the live transcript button. If you'd like to be in a breakout group with this functionality, then please do message Sarah Q or Adriana and they can arrange this. Where possible, please have your videos on just because we know it can really enhance the conversations that we're having virtually. But we ask that you stay muted other than when you're in breakout room discussions. And we'll also be having a bit of an interactive session later. So we will ask people to unmute then. This session is being recorded, all of the bits in the main room, breakout groups won't be, and we might be sharing some of the videos online afterwards as content. And we will be tweeting about this workshop on Twitter from our Q Twitter account using the hashtag QEvent2022. So please feel free to join the conversations during or after the event as well. And if you've got any issues with the tech throughout the session, please do just message Sarah or Adriana and we'll hopefully be able to help. Perfect, Sue, I can see that you've also been able to join and hear us now. Great, so moving on to what we'll be doing today. So we're here to talk, hopefully if you've joined the right session, we're here to have an honest conversation about working in partnership. So what it takes to do this really well and sharing practical tips and collaborating with others. So for myself personally, I know partnerships are important, but from this session, I really want to get under the skin and sort of understand some nuanced learnings to get under the skin about what we regularly read and hear about partnership working in practice and bring this to life more through hearing from some of our case studies. So we know that now more than ever, we really need to work collaboratively if we're going to deliver consistently high quality health and care services. And in Q, as you know, we regularly collaborate and work in partnership with others. So most recently through the Q Lab programme, we've been working with NHS England, And we've previously worked with Mind and have also done some work with Nesta, National Voices and Improvement Summary. So we haven't always got everything right when it comes to partnership working. We'll put our hands up and say that, but there have been some really valuable learnings. And we've developed our Leading Successful Partnerships Guide, which was through our learning from the work in QLab UK. So there are 4 main principles that really stand out to us as being important, and we'll share more on this shortly. So the Q&A session that I'm really excited about today is designed to give you the opportunity to hear from 2 different case studies who can really speak to these 4 principles and bring these to life further. We hope that they'll help you think about your work in a new way and unlock some new thinking. We'll be running the Q&A session using a celebrity interview method, which is a liberating structure. So some of you may be aware of this. We're using it because this sort of format really gives you the chance as participants to actively contribute and to also explore the most relevant learning that resonates with you. So in a nutshell, and we'll explain this as well a little later on, we'll start by asking a few questions to our speakers, and then we'll hear some initial learnings and reflections about these principles from them. We'll then have some time with some individual reflection and small group discussions in pairs and 4s, and we'll use the 1, 2, 4 all method for this. And in these groups, we really want you to generate additional questions for our case studies, and we'll then all be coming back into the main plenary, and we'll have time for each group, hopefully each group, to ask the case studies their questions. This 1, 2, 4 method can feel quite abrupt, but please don't worry about this. It is a method to engage everyone in generating additional questions. So this slide just gives an overview of the timings, but we'll share this with you later on in the session. So enough from me. I will just do a quick check-in. You probably all know the drill by now to get us all warmed up after lunch. So I'm going to ask a few questions, some easy, some a bit harder, and this is meant to be fast-paced, so just your initial reflections, don't worry too much and think too much about it. So pop your answers in the chat. The first one is, on a scale of 1 to 9, how are you feeling about this week? And in Q, we often like a animal picture or a cat picture. Okay, very varied. 1, 8, 7, 3, 4, 5. Too fast paced to get an average of all of this, but I think we can say we're feeling quite varied energy levels. Great. Moving on to the next question, now a bit more serious, I'm afraid. So when I hear the words partnership or collaboration, I think of ... Opportunity, sharing, lots of people trying to do stuff together, complexity, shared goals, mutual benefit, sharing ideas, little action, problem solving. Nice one, Rachel, working with, not to or on. We're in this together, we're all people. Challenging, but worth it. Yeah, lots about connection, working with, better than the sum of the parts. Politics, yeah. We'll get into this in a bit more detail afterwards as well. I'm seeing that chat slowed down now. So the next question, again, being quite fast. The best thing about working in partnership is learning, yeah. Lots of learning, connections, people, sharing, diversity of thought, nice. Building relationships, hearing what others think, developing trust, understanding others' difficulties, sparks of creativity. Great. Perfect. So I did say this is going to be fast, so we're going to quickly move on to the next question as well. So the most challenging thing about working in partnership is ... Making it happen. Lack of resources and time, different agendas, yep, multiple views, people. People's own agendas, yep. Time. lots about time, different people using the same words with different meanings, prioritizing listening over talking, differing priorities, forced views from the top. Yeah, interesting, Linda. And people's perceptions of other people's agendas. Great. I feel like we could spend the whole 90 minutes just doing question after question like this. Understanding it's okay not to agree. Yes, John. Perfect. Great. So I will just move on now. We will have time to be a bit more interactive in a little bit as well. So I am going to be speaking for about 5 minutes or so about some of the learnings from our work in Q. And as you actively listen, I just want you to have a think about anything that resonates with you or sparks any thoughts. And our speakers will be bringing some of the stuff that I'm sharing to life shortly. So Q's Guide to Leading Successful Partnerships sets out some of the principles that we know really underpin effective partnership working in the health and care system. For all of us working to improve health and care, we know we need to work together if we're going to meet the needs of local populations and ensure high quality care is delivered as standard. So the guide, which we'll share on the next slide, provides advice and insight to help improve your team's organisational relationships and helps you set up effective working partnerships that support improvement in health and care. So the guide is structured around the different stages that you'll go through when you're establishing your partnership. And we know that identifying the stages is really important and is often something that is rushed or not given sufficient resources or team capacity. And this can be quite hard to dedicate time to, but the alternative of not spending time here is wasted efforts and failed endeavours. So the first stage is around deciding whether or not to enter into a partnership. So we know that sometimes it can be decided quite quickly that a partnership has the right opportunity, but it's worth taking stock at this point to decide whether it's definitely the right decision, because we know that working partnership can be difficult and it can come with lots of additional work and resources. So it's really important to decide whether at this time, whether it's the right option for you and your organisation. And of course, it's important to state that partnerships aren't the only way to achieve change either. So it could be through collaborations, alliances and cooperation. So there is a strategic decision about whether a partnership is the right approach. So the second stage is around approaching partners. And in a way, other people have said you can sort of consider this stage a bit like dating. So you might be reaching out to different organisations, trying to understand what the chemistry is like between you both, how your values align, and whether you think there's real potential for you to achieve greater impact by working together. So at this stage, it's really important to have honest conversations and not make assumptions. Then the final stage is around establishing your partnership. And this is where there's a lot of work to really iron out some of the details about how you're going to work effectively together in the future. So our work has also highlighted institutional flirting. Dorian, that's a new term we can add to our guide maybe. So our work has highlighted that there are 4 common principles that really underpin effective partnership working. So the first principle is around having clear and common goals. So it's really important that when you're working with another organisation or multiple organisations, that you have a shared view of what you want to achieve working together. And we've learned that it's really easy for organisations to talk at cross purposes. So you want to be asking yourself some questions here, like what's the nature of our goals? How aligned are they? Do we have a shared view of what we're going to achieve together? And what does success look like? So the second principle is around ensuring a transparent and equitable distribution of power in your relationship. So it might be that one organisation is coming with more money, whereas another is coming with quite a different type of expertise. So it can be really helpful to have open and honest conversations early on in your relationship to surface this, and especially surfacing what the different power sources we're each bringing and what might some of the barriers to equity be based on this. And doing this early on will allow you to just have a really transparent understanding about the power dynamics, and it should make it easier for you to name and call out issues that you may experience then in the future. The third principle is around adequate resourcing. So making sure that all partners are putting in the right amount of staff, capacity and resourcing to make the work successful. So having open and honest conversations is a theme that runs throughout this whole guide. So some of the things you might want to be exploring here are we both working and committed to achieving our goals together? Is there sufficient buy-in from all organisations? And what are the specific roles and responsibilities we all need to do to make this work successful? And finally, the final principle is all around establishing a positive culture. Now, for this principle, you want to be thinking about how you can build trust and respect into your relationship, and really taking the time early on to get to know the people you'll be working with, understand their values, their motivations, and how that's going to affect how they work. Establishing trust, accountability, and respect in your relationship really is important, and it's going to make it much easier for you to overcome challenges together in the future. That was a very whistle-stop tour. You can find far more detail and information on our full guide on our website, and I know the link, Gillian's put the link to the guide in the chat. So we want to really try and understand and explore these principles and bring them to life a bit more through our Q&A with our case studies. So I'll now hand over to Jo to take us through the next part.
Thanks, Zarina. So as Zarina explained earlier, we're going to use the liberating structure method celebrity interview for this. So I'll start just by asking a few opening questions to our four speakers. Sarah, if you could just put a spotlight on the speakers so everyone can see them. And so we'll have initial Q&A, and then you'll have some time in smaller breakout groups to reflect on what you've heard, generate some additional questions, and then we'll come back together and I'll ask as many as I can to unmute and ask your questions and share your reflections to the panel. So first of all, let's just start off with some introductions. So Rachel and Alan, you just introduce yourselves and tell us a bit about the Aware IBD project that you're working on together.
Hi everyone, I'm Alan Lobo. I'm a gastroenterologist. I'm a professor of gastroenterology in Sheffield, and I'm the chief investigator for an Aware IBD project, for which Crohn's and Colitis UK, for whom Rachel works as the lead organisation. So that's the sort of basis of our partnership. Crohn's disease and ulcerative colitis are inflammatory bowel disease, so these are quite complex, long-term conditions with complex needs, and so the project was around trying to put people with the conditions at the heart of reorganising their service and essentially asking that question: what matters to you as part of the project? And so, because of the complexity both of the condition and the services that need to respond to that, we actually felt that a partnership was a really key way of trying to address the issues that rise from that.
Yeah, so I'm Rachel. I'm the Research and Evidence Manager at Crohn's and Colitis UK. So with the leading UK charity for people living with inflammatory bowel disease, as Alan has mentioned. And our role in this project, this partnership, is really ensuring that the patient voice is at the centre. We're feeding in all the intelligence from our members, supporters into the project, and also really key leading the patient oversight committee, who really hold the project to account, and that body of patient expertise. So it's really all about putting patients at the centre, and we have a patient really leading the quality improvement work up in Sheffield as well, who's employed by the trust, and we're really looking forward to taking the outputs of the project and disseminating them across the UK, as well as part of our work on quality improvement across the 4 nations.
That's great, thank you. And we're so pleased that you could make time to join us today. I think there's so much learning from that others in the community will benefit from in terms of working with third sector organisation, NHS organisations, and the various partners in between as well. So yeah, look forward to discussing that shortly. Jo and Tiffany, I'm also really pleased that you could both join us today. I'm so yeah, really interested to hear more about your project. Can you just introduce yourselves and tell us a bit about your REACH project?
Thank you so much. So my name is Tiffany Wishart. I'm the clinical lead for the North East area of London, for London Ambulance Service. And our project is called the Remote Emergency Access Coordination Hub. which initially started off as the BARTS Emergency Access Coordination Hub, which we'll talk more to you about later. And in short, it is a pathway set up for ambulance crews to call an ED consultant to discuss the care of their patient and the best place for their patient to go. They can book appointments, they can do virtual consultations. So it's about bringing the ED to the patient. And we've had a really, really successful pathway with thousands of patients now going through, in excess of 4,000 for the ambulances, and similar for the ones with only 65%, only 35% being conveyed, 65% being left in the community. Over to Jo.
Hi, nice to meet everybody. I'm Jo Moore. I'm a Senior Improvement Advisor at Barts Health. By background, I'm a neurophysiotherapist, and I've been working in the unplanned care programme here across all 3 ED sites for the last year or so, and leading on the REACH project, which has been an absolute pleasure, and I can't wait to talk to you about.
Thank you. So Zarina just spoke there about the sort of 3 stages of forming a partnership. I was wondering whether those stages, were they conscious for you when you were sort of identifying and setting up the partnerships that you have, these projects? And maybe you could share any reflections you have about what you learn about those different stages of partnership. Tiffany and Jo, should I start with you first?
Did you want me to go first, Jo, on this one? So I mentioned previously that we had the beach prior to the REACH, and the reason I think that the beach wasn't particularly successful when compared to the REACH is because we didn't really have a partnership when the beach came to fruition. It was a pathway which was worked up by Barts Health. It was effectively handed to the London Ambulance Service and said, we've worked up this pathway, can you please get your crews to call us? So there wasn't really a relationship built there. But as part of the beach happening, we were then reaching out and forming these relationships. And I think, to be honest, it was subconscious. We didn't go through, we have clearly been through those stages, but we didn't consciously go through those stages because it kind of happened by chance that we came together. And then we're able to work more collaboratively to work up the REACH. Thanks to Jo joining and bringing an absolute QI approach to how we joined it all up.
Yeah, I think it's really resonant with Zarina's introduction about spending time on partnerships and actually really valuing that space and putting resource into and energy into that space at the beginning. I think because of a lot of the original beach model happened in response to COVID, which was obviously it happened at pace. It had to be stood up quickly, and there wasn't so much resource put into how it was set up and those relationships at the beginning. And we found that as we went through the beach model and then eventually stood that down, and the learning we had in that space where that model was an excellent, it was delivering really good results in terms of outcomes and patient conveyance numbers and experience for staff and patients, but actually the sort of collaboration aspect of it wasn't very healthy, and there were lots of issues around transparency of data and trust and agendas and people's vision of the service not completely aligning, and that was really where this partnership piece between Tiffany especially and myself and other colleagues in this sort of core team, that was where this partnership work really started to bear fruit. I don't know if I'm going on to the next step actually, Jo, so stop me if I've going into another bit of question.
We'll come back, I think. I think you've got some really useful learning on sort of the transparent and equitable powered distribution principles. So let's come back to that. One of the things I have learned working at Q is that everyone loves an acronym. So yeah, we're talking about BEACH and REACH and what they stand for, and actually that's really important, isn't it? So having the BARTS in the BEACH actually was quite a signifier of sort of power and the challenges there. So let's come back to that. Alan and Rachel, do you have any reflections on the stages of partnership and what you've learned about that?
Shall I go first, Alan, and then you can follow on? Yeah, Alan and I were having a talk about this yesterday. I mean, I think our partnership came about very much from an opportunity from the Health Foundation funding, and we went out to kind of trusted partners and said, this opportunity, could we put something together. But I was also reflecting on that happened in March 2020. And then very quickly we were all into COVID, and actually the partnership didn't really meet face to face for a couple of years after that, so I guess it's about not being, it doesn't have to be perfect, the partnership formation. We've got a really strong partnership, even though we weren't able to kind of have those face to face conversations early on. And what really helped us, I think, was that kind of clear and common goal. We were all very focused on what we were trying to achieve, which was improving outcomes for people living with the conditions, and actually having a very kind of clear theory of change raised some issues that we then worked through as a partnership. So yeah, working with trusted partners, not necessarily personal relationships, but institutional relationships, and then that very clear goal. I don't know if you want to add to that one, Alan.
No, I obviously agree with that. The opportunity came from the funding, but we'd had pre-existing discussions. I've worked with Crohn's Colitis UK for years, so I'm well aware of their track record and the goals that they've had for years in terms of patient care and policy, and their interaction with clinicians for years. So I knew that would be a great group to work with, and so when the opportunity came to partner on this project, it was an obvious step to take. So yes, it was partly opportunistic, but based on the pre-existing institutional relationships.
That's a really useful reflection about the infrastructure that enables the relationships to form, opportunistically, perhaps. So yeah, you touched on something there about the clear and common goal principle. So Jo, can we come back to what I stopped you from exploring a bit further about, I guess, the power distribution, having clear and common goals across the different organisations that you're working with, and really trying to engage and work well together.
Yeah, so maybe a little bit of context is helpful here. So the beach, stood for the BART's Emergency Access Coordination Hub, which, as Tiff explained, is this sort of single point of access for emergency referrals coming into secondary care. And it actually encompasses a few different organisations. So obviously BART's Health, which is a large multi-hospital organisation, NHS 111 and the London Ambulance Service, as well as more recently our community and primary care team. So it's a big sort of system-wide approach to changing care. And when we first had the beach, which was the BART's version of this, and it stopped, there was time then to really think about why that happened and what was missing. And actually, as you said, having a sort of shared vision, a shared reason as to why we were doing this was really missing. And one of the things we did very early on in that pause stage was to meet as a very big team on a Teams call, because similarly to Rachel and Alan, we couldn't meet in person at that point. And there were about 40 people on this call, and we just did a Jamboards and asked, what are we doing and who are we doing it for? And everybody put their post-it notes on, and it became very clear very quickly that we had this very sort of clear synergies between what we wanted to do, which was to keep patients safe and reduce, system pressure, but also we were doing it for the patients, and we were doing it for staff, and we were doing it for the system. So it was very clear that we all were actually all aligned around these things. And other things we do, which Tiff will speak to more, is we really listened. So there were a lot of sort of theories going around as to why Beach hadn't worked, and a lot of it was around crews feeling disempowered or people weren't being listened to. And actually what we did then was go out and we did a huge sort of listening exercise with our crews to say, how did you find it? What went well? What didn't go well? What would you do differently next time? What are your ideas for change? And interestingly, what matters to you about this? Does this matter? Is it something you want? And overwhelmingly, the response was, yes, this is a really good thing. We really do want it, but with the caveats of this, and this needs to be changed. And please hear that for it to work. And the name change was really key. And I think this is one of the biggest learnings for me personally, was that actually when people were talking about Beach, it was very much owned by BART's Health. It was something that was something that was, it seemed like it was being done to other people rather than collaborated with. And actually just by putting it out to consultation and saying, what do you want to call it? Which went through a huge round of different acronyms for this service. And in the end, we only changed one letter, but that letter was so meaningful to so many people, and it brought everybody around the idea, and this shared sort of collective ownership really started to embed. So I don't know, Tiff, do you want to speak more to that?
Yeah, I think you've covered off the majority there. So as Joe said, we were expecting that crews would sort of feel like that they were being done to and they were losing their autonomy. Because initially when the beach came out, it was please call for every single patient you're taking to the hospital. But actually the overwhelming majority didn't feel that way. There were other things that they wanted to change about the pathway, the way that they accessed the pathway, because there were a couple of steps which made it not very user-friendly, and different bits and pieces around what happened when they get to the hospital to improve the handover of patients that still went to the ED, and that side of things. And actually, I think the biggest winner for the pathway was listening to the crews. Although there weren't any huge changes, it's such the popularity of the pathway has increased massively just by listening to the crews and changing things that the crews wanted to be changed.
I think that there's something also to say around data here as well, isn't there? Tiff, do you want to speak to that data piece around sort of transparency of how we were reporting?
Yeah, so it was really, really tricky because we've got data on both sides. We've got London Ambulance Service data in terms of on-scene times and the details from the call, which always originated from London Ambulance, whether that be 999 or 111. And then we've got obviously the hospital data. So it was really tricky to evaluate the data because both services were kind of looking for their own meaning of the data. They wanted to look for, London Ambulance Service wanted to make sure we weren't increasing our on-scene times and we were getting benefit for us and our patients, whereas Barts Health wanted to look more into whether they were getting less patients into their ED, and was it initially, obviously it was set up initially because of COVID and social distancing and keeping patients out of ED where possible and booked appointment times and that side of things. So it was really tricky in terms of getting what we both needed out of the data, as well as sharing the data in terms of governance and DPIAs and various other things, which eventually led to us getting an independent data analysis.
Oh, wow, that's fascinating. And yeah, I think you touched on there both the technical infrastructure needed for that sort of data sharing and the analytical skills, but also how people interpret stuff and how it kind of prompts conversations and the different priorities people are concerned about. So yeah, there's a lot there. Thank you both. And Rachel and Alan, yeah, I'm just really kind of aware that obviously the work that you're doing, it's really is about collaborating really across the health and care system. Just wondering if you can share any reflections, maybe build on what Tiffany and Joe have said about how you sort of generate a positive culture across organisations that can be very different, working with different priorities and have different challenges and issues that they're also dealing with.
Yeah, shall I make a start, Rachel? I was just picking up on what Joanna said there about what you asked about the common goal. So that sharing the common goal, I think, has been consistently articulated. So it wasn't a single slide that we put up at the start of our discussions. It permeates every part of our discussion. So the what matters to you question, the patient-centeredness of it comes up in every discussion. And it also built on discussions that we'd had with the clinical team and is at the core of what CC UK did. So we've had endless discussions with the clinical team about what matters to patients, what the clinic should look like, how the service should look like. So when it came to putting together a partnership to deliver a specific project, a lot of the groundwork had already been done. So we built on that. So understanding that vision for the project has built on a vision that was already there. And the other just comment I'd make about the partnership, and ours is a partnership across a number of different organisations, a trust, a charity, CC UK, university who do the evaluation. But actually within that, there's several other partnerships within each partner. So the partnership within our clinical, within the trust, comprises the clinical team. So we have to pull together a group of consultants who have their own views and what they need to pull in one direction. We have the organisational development department who need to be aligned. We have a management team, both for the nurses and for the consultants, and then overarching sort of service and business managers. So there's several partners within each part that we have to continually work to, so that they all understand that vision that we started with. And then on top of that, and most important and central to that, is the partnership with the patients, which is what CC UK have been sort of instrumental in, which Rachel was going to say a bit about too.
Yeah. So for us, it's that key. The patient's really leading the project, really holding the project to account. And as Alan was saying, the different layers within a partnership. There's also, for us, partnerships within partnerships. So we partner with 17 organisations as part of IBD UK, which includes the Royal College of GPs, Royal College of Physicians, and we're bringing all of the intelligence from the benchmarking exercise that we do from that, the service self-assessments, the patient surveys, into the project and using that to disseminate out. So it's you've got kind of the different layers of peeling an onion. You've got the kind of core group, and then we've got all of the different aspects of that and internal stakeholders within the charity as well. But having that really clear goal in terms of what we're trying to achieve. We might pick up on this later. I was just going to mention the thing around adequate resourcing we were talking about yesterday. How you know what adequate resourcing looks like at the beginning of a project is something, because we're doing quite a bit of work to reach out to unheard voices as well. We definitely didn't appreciate at the beginning quite how big a project that could be, and actually until you start uncovering things and working out how you set a budget at the beginning with adequate resourcing is challenging.
Yeah, definitely. Before we sort of go into sort of smaller group discussions on this, is there anything that any of you want to add in final sort of initial reflections before we explore this further?
I think there's just something that I would add around the sort of power distribution dynamics, psychological safety piece. And I think something we've really learned in our space is that, the NHS can be quite a hierarchical institution, but actually the value of creating psychological safety in this sort of collaborative shared space where there's a very flattened hierarchy and everyone's ideas are heard and it's, examined equivalently was absolutely crucial for this to be able to, for trust to be built and for people to be able to work together and have ideas together and be wrong together and learn together. And I think that sort of is everyone's responsibility in this space, because one person's behavior can affect an entire Teams call or an entire room of people. And we've been quite careful about that in terms of our own sort of group behaviors, that we are really clear that it's a safe space and that there are no silly ideas and that everybody has a valid opinion regardless of your position or profession. And I think also having regular meetings, the regular spaces for continual catch up, either as a core team or as Alan mentioned with more disparate teams, depending on what you're doing, is also really central for those relationships to be maintained and to keep that level of dialogue going and it not to drift, but also to maintain the teamness and the safety aspect of it.
Yeah. Alan, you're unmuted. Do you want to share one reflection?
No, I completely agree with that. And I think we initially thought that we would have our steering group meetings relatively, we'd start frequently and then build up, tail them off and maybe have them less frequently. Actually, we've kept going and at the same frequency, and that level of discussion I think has helped with all aspects, the team building, the transparency, it is really difficult to find the time for that in everyone's busy week, but it's been really important.
Some common themes I'm hearing already today: the time, the people. I love that idea of like safety and team. Great. So, we've got an opportunity to come back and keep asking you questions and to share your learning shortly, but we want to break into smaller groups now to enable people to have, just discussion with your peers. So I'm just going to have 1 minute now, so the individual reflection, and then Sarah's going to move you into pairs, and then you'll have 6 minutes sort of in a pair, and then you'll be moved into groups of 4 for a 9-minute conversation. So really enjoy sort of smaller group discussions with your fellow key members, and we'll come back together and then ask some more questions to the panel. I will be asking some of you to unmute to ask your questions, and nice to hear some of the voices. Do be prepared for that when we come back together in plenary. I love having smaller group conversations, and I hope you all enjoyed that too. So we've got about 20-25 minutes now, and it'd be great to hear as many voices as possible from the floor. Get to ask your questions or share any reflections you have and you discussed in your smaller groups. Ask them to our speakers. We've got about 8 breakout groups, so I'll just try and take 2 at a time to see if we can get through all 8. So if I just call out sort of the names in your group, and maybe one of you can be brave enough to unmute and yeah, ask your question. So it was the room 5 was Anita, Diane, Graham, and Jill. If you want to, one of you want to ask a question, and then room 7, can't read my own writing, Kath, Mike, and Wendy. So question.
Hi.
Jill.
Hello. I'm Jill Donnelly from Newcastle Hospitals. One of the things that we talked about in the room, and sorry, it didn't formulate into a question, but maybe would like some insight into, I've got a note here for transparent and equitable power. And I suppose that power struggle about who's in charge. Is it the person who's allocated the most money, allocated the most resources, is the bigger trust, the bigger organization? And I just wondered how that was overcome or experienced by the panel.
Great, thanks, Jill. We'll come to that. So Kath, Michael, Wendy, do you want to ask your question? Mike.
So we had one, we had a couple, but the first one, just if you were doing this again, knowing A, what you know now from the experience you had in the partnership, and B, having looked at the partnership guide, what might you do differently? And the second one, if we're allowed a second one, is the final principles around culture. What levers do you think you can pull in order to create that positive partnership with culture?
Thanks, Mike. Okay, Joe, Tiffany, any reflections from you on those questions from Jill and Mike?
Do you want me to go? Should I go first?
Yeah.
So I think just to speak to Jill's question about the power struggle, I think we were sort of in a slightly not lucky, but just well-positioned space in North East London, because what we did was based on quite a few years of partnership working that had happened previously with a different service called the Physician Response Unit. So there were already very good sort of flattened hierarchy links between LAS and the beach team, as was in that first instance. I think there was a space that was slightly easier to build on in terms of not feeling like it was a takeover or a big organization because they have more money doing something to another organization. I think there's something though about the people in that space, and there were lots of very sort of senior clinicians in that space. Tiffany is one of them, who also brought a very much an open and transparent and inclusive mindset with them. And I think leading by example in that space really did set the tone for the rest of the work that followed. And I think also the behaviours of other people that came into the space later, which may have not been quite so flattened if it hadn't been set from the beginning. I don't know, Tiff, do you want to speak any more to that for that point?
Yeah, no, I think that's really, really valid. And in terms of sort of who was in charge, I think it was realised very early on that one couldn't work without the other. So there was no case of one person's in charge or one person's leading. The pathway wouldn't work if both organisations weren't on board. So I think equality was assumed very early on, and we had equal input and listened to in equal measures, I would say.
Yeah, I think so. And I think to the other point of what I would do differently if I started again now, I think I would have more support with comms. I'd have more governance, and I would have more support with BIU as very practical things. But I don't know if I would do much differently in terms of the relational aspect, because I think that piece is a real positive learning for all of us that have been in that space. I think I wrote down a few things, sort of shared things. I think shared vision, shared spaces, shared data, shared learning, and shared celebration are things that have worked really well for us. And I think even celebrating the little wins. So we did something called a perfect day, which was a little event really, but it brought all of us together around this really clear purpose for one day. And I think things like that I'd probably do a bit more, because they really drew us together. They really bonded the team. We went for drinks afterwards, and that in itself was such a bonding thing to do. And it seems so simple, but looking back, it was those things that sort of brought us into the space we're in now. So maybe some more of that in the beginning.
Thanks, Jo. Alan or Rachel, anything you want to build on there?
Shall I go for it? I agree with all of that. There's lots in there that I think we would echo. Just perhaps to add to that, the power differential. I think we were very fortunate. We came with a group of people who accepted that everyone in the room was going to have an equal say, and we pretty much wouldn't have tolerated anything else, but didn't need to do anything differently because that was the behaviour of the people in the room. And then that has fostered more of the same type of behaviour because it's just been the accepted form. The other point I've made about leadership is that although Crohn's Colitis UK are the lead organisation, I'm the chief investigator, actually everyone in the project, different parts of the partnership have shown leadership at different points and different, so for example, the people with the lived experience who run our oversight committee, we've used some of their skills to lead focus groups or to develop written information, and they've often taken that on board and said, right, we'll run with that. So a complex project across complex condition with complex partnerships has been made much easier by that sort of leadership at different parts of the team emerging at different parts of the project, and that's made it really, that's been great. Actually, how we fostered that, I don't know. I think that's by, I suppose, by giving people opportunities and then encouraging when the opportunity has arisen, has allowed that to happen and not said, actually, that's not what you do, but just allow people to run with things. Yeah, I think those are the main reflections I've had to add to what Jo's just said.
Yeah, just to add to that, I really liked the point about the sort of shared celebration. I was just reflecting, we had our first kind of day last week where we all came together in Sheffield for the first time. We'd been doing this project for nearly kind of 2 years now by the time you've got all the contracts done and got started. And it was really positive just to get everyone in the same room, see how bought in everyone was, especially kind of many clinicians who we haven't kind of met before, and all the IBD nurses, and having the management there. So taking those opportunities, and we would have loved to do that earlier, but COVID allowing, obviously. So I think that is really important, taking the time out to do that. And that the point earlier around listening, I think we did some work fairly early on with our patient oversight committee, supported by National Voices, who are a support partner on project, to think how could we kind of change that into a more, into us, from us kind of talking to them and holding to account, and actually getting them involved in setting the agendas and changing it more into a conversation, and really moving much more to a co-production model, which really helped, just kind of taking time out to reflect with others, get some expertise, and actually shape things around.
Really important, isn't it? Yeah. Some real nuggets of gold here. I'm glad this is being recorded so I can listen back. Great, so let's go to another group now to ask your question or share a reflection. Alan, Andy, Cecily and Gillian, do you want to ask your question? And you're on mute.
Oh, I think I'll shift.
Oh, go on, Andy. Yeah.
No, I spoke in the morning one session I was in, so please go ahead.
Oh, Gillian, great. Thank you.
No worries. I think Andy may do a better job. We may have gone slightly off piece, but we talked about partnerships that you can choose and the ones that you can't choose. So particularly thinking about statutory partnerships, relationships with ICSs, ICBs, etc. And we're talking particularly about the power dynamic in those relationships, and what people bring to those partnerships, and the fact that they, I guess, may not necessarily be perfect to start with. You're not, necessarily dealing with an easy situation, but how can you make the best of that situation? And that might be what Andy was going to come in and talk about. I don't know if you've got anything else to add, Andy.
Thank you.
Well, I think you summarised that perfectly. That there was one more thing we were just heading on to, because it was starting to get a bit controversial. There was lots of talk of democracy, because you've got to put it that way. But then we talked about the need for involving the patient, be that at population level or the individual, and they can often be quite a reluctant and challenging partner, but they're absolutely essential. So I guess there's a couple of points in there that move on to, so how do you include the patient as a partner or the population as a partner?
Great. I love a bit of controversy. Let's come back to those. I think we've got some really good reflections from the speakers on those, but I just want to take another question or reflection from another group. So the group that had Jan, Hilda, Iona and Sue, do you want to just quickly ask your question or share your reflection? Who's going to unmute first?
Hi,
Jan.
so it's Jane. It's not Jan,
Jane.
but it
Oh,
comes
sorry.
up as. That's okay. So we talked a lot actually at length about barriers and challenges, but I think one of the questions that we come up with was a practical one about sharing information or information sharing and having 2 different or 3 or 4 different systems, and how do you make that work?
Great, thank you.
Okay.
So any reflections, Alan and Rachel? Do you want to maybe reflect on that question about how you involve the patient?
Yeah, I was reflecting on the patients being reluctant to partner, which hasn't been the case in our project at all. And I don't know whether that is because from the very start, it was always that the patient's voice is going to be at the heart, and it's about what matters to you. But I know that, yeah, it's often challenging to get to that point. One of the challenges we had with this project was when we got our patient coach actually employed by Sheffield Teaching Hospitals, there was a lot of hoops to jump through in terms of HR processes and it being something new, something different. And that really took a lot of perseverance, and I can't claim credit for that one, but Alan and the team up in Sheffield really had to persevere. But getting the right person in the room to talk about it early, I think was really or would have been even better. Anticipating challenges. But yeah, I think, well, we would advocate patients are involved wherever appropriate and involved rather than being being consulted. But it's not easy to get to that point sometimes. So yeah, that's my reflections on that.
Maybe just to add to that, I would have no reservations about involving patients, and I've not, again, obviously our experience has been with a particular patient group, but I've never, even in different forums, had anything but a positive experience in terms of the perspective that people give, always being something slightly different, always being something valuable. And I can't speak highly enough of that. Been through research projects. It's, as you all know, nice have patient representation as part of their standing committees for technology appraisals and for clinical guideline developments. And my experience of those has been incredibly positive. So I would have absolutely no reservations and have really enjoyed it. And it's brought a different perspective to our work in all of those areas. So we haven't seen it as a challenge at all. And we've done it at different levels. People's feedback of having been asked is that they've been delighted. We've done it at different levels through questionnaires, through smaller focus groups, through a regular patient microsystem group where we've got patients as part of the committee, but the leadership or the chair is from a patient as well. And people have enjoyed being asked. They feel they're slightly more in control of their care and therefore slightly more in control of their lives too. It's been very positive. So I can't speak highly enough of that involvement. And almost to the extent that when I go to meetings, when people are starting to talk about service change and there isn't a patient voice in the room, even unrelated to inflammatory bowel disease, it just doesn't seem right. And it almost seems impossible now to be creating service change without that voice.
Yeah, thanks.
Just
Alan.
quickly to add to that one, Joe, I was going to, yeah, I mean, we spend a lot of our time as the patient charity getting people involved in research, getting people involved with our works, getting people involved in sitting on committees. So I would, if there are challenges to finding the right people to involve in work in quality improvement or elsewhere, then do reach out to whoever the relevant patient charity is, because I'm sure that they will have a team that can help.
Thanks, Rachel. So Joe and Tiffany, there are two questions. One was about the partnerships you choose, the ones that you can't, and then some practical things about sharing data in different systems. Do you have any reflections on either of those questions? Joe, yeah.
So I think I just want to speak to Alan and Rachel's point about the patient participation, and I think this is one thing actually. If I could go back and say I wished we'd done this better earlier, it would be that in that we could have done a lot more in terms of involving the patient's voice in the design of this, and possibly the reason we didn't prioritise it as much as we should have done, even though we've got patient experience coming out of our ears and we've had loads of focus groups and stuff. We didn't have a patient on the design team, and I think that was probably because it's not a patient-facing service. But that was a mistake. Wish we'd done that differently. And now where we are is we are actively part of our community leaders and our health champions in each of our boroughs. We've got 30 health champions in each of our boroughs, and they now are part of our network of understanding what good emergency care looks like to our communities, all our different communities, and how we can, provide a route of access that makes sense to our communities, and reach sits within that as one of the work streams, which is much more of a strategy. But yes, I agree. I feel the same. I put in the chat actually that I think my idea of patients' relevance in this space has gone from sort of participants all the way through to teachers and mentors, and actually they know exactly what they need for their communities, and we just need to listen and ask, and the answers are in the room often. Sorry, Tiff, do you want to speak to that as well?
Yeah, no, I absolutely agree. If I move on to the sort of the IG side of things and sharing information, I think it all goes back to what I put into the chat. It's all about early conversations. As soon as you've got any sort of pathway change idea which involves another organisation, don't work it up in silo. Reach out and have those early conversations with the other organisation about your ideas and the concept, so then you can actually work together to create the idea, and brainstorm all of those barriers that you might come across, such as IG, because not only have you got the two clinicians having conversations, but then you've got the comms having conversations, you need to link up the IG teams, and there's so many different departments that you need to link up and include as part of the process, that the sooner you have those conversations, you can work together to build the pathway and the processes, which makes it a lot simpler in terms of getting that pathway up and running and not having to undo things and try and sort of do things on the hoof, as well as working up what data set you're going to collect and analyse to evaluate the project or pathway.
Yeah, and I would add to that finance as well. So I think in quality improvement land, we don't maybe think so much about those sort of more structural pieces, but actually I think the governance, the workforce, the finance, the IG, the data, all of that has to be part of this initial driver diagram, whatever it is you want to call it, that is going to map out how this project is going to work. And those, like Tiff said, absolutely need to be part of the design phase together, rather than add-ons later, because inevitably there will be things that are needed from all of those spaces which you don't have later down the line. It's much harder to get retrospectively. So it's about putting everything, front loading all of those conversations, and the finance team don't need to be at every meeting, but it's very helpful to have them in the beginning, just to ensure that you're not missing or duplicating something that you shouldn't be.
Thank you. So I'm going to try and get a couple more questions in, see how many we can get through and how many reflections we can add. So the group that had Des, Francis, Catherine, Tony and Victoria, do one of you want to unmute and ask or share a reflection and ask a question?
Button anybody. We had quite a wide-ranging conversation in a very short number of minutes, and there were kind of some practical issues and questions we touched on, and some much more behavioural change ones. And I think the practical ones, if you might like to touch on one of them, I think one of the groups had a really interesting conversation about protected time. Actually, it's so valuable to have the lead professionals, clinicians with protected time to deliver into that partnership. So we're kind of interested on some perspectives on that. We had a practical conversation about what tools, how overt were you in your use of quality improvement and bringing people together, especially if they were not necessarily coming from similar organisational backgrounds? You know, that commonality of language. There were two practical questions. Then we had a big behavioural piece that I think perhaps people have spoken to a bit more already about team awareness, identity and values. And, you know, sometimes these are two projects that have gone really well and you're getting on great. But we're kind of interested about, what happens when it all goes a bit wrong? Should we give more effort to that organisational development piece of the team?
Thanks, Catherine. And the group that had Mary, Michelle and Ron, do one of you want to ask your question?
So I think it's really interesting because actually I think we were talking about that is how do you quantify the value of your time that you spend connecting and forming these relationships, particularly across different tribal groups. If you're in clinical, you know, how do you reimburse people for their input? And then I think we talked about lots of different things around patient involvement, which you've covered. So that was, I think, our main question. I don't know if anyone else has anything more to add. We ran out of time.
Any reflections then on those questions? So quantifying time, protecting time, and some of the kind of QI tools and methods we use.
Shall I start on a couple of those? Protected time. Oh gosh, I wish I knew the answer to that. I did negotiate some time for part of our team with our clinical director to take out once we got the other funding. But obviously part of the reason we wanted to do the project was because we were under immense time pressure and long waiting list. To then negotiate for time to stop seeing patients was slightly counterintuitive. So I had to make the case based on just on the project and the potential of the project. But now that we're in a phase where we need to look to sustain what we've been doing, we need to make the argument again. And I think it is really important to think about what metrics the trust or your organisation is going to respond to. It's going to be different across different organisations. It's probably important not to have too many of those and to present them in a way, to think about how you're going to present them. And there's a literature on this that people can refer to, but think about the metrics, not having too many, and think about how you're going to present them, and also maybe build in, again, this is sort of quite common knowledge I think to all of you, is to build in some changes that are of benefit to the staff and not just to the patients, because that will help sustain it too. So I think that, I guess those would be my comments on the protected time and the metrics. And you know, the senior managers in our trust, as in everywhere else, are pretty hard-headed and want to see not just the potential and of the project, they want to see what it will actually deliver. So we have to generate that data.
Thanks, Anne. Joe or Tiffany?
I'll come in briefly on protected time. I think the short answer is no one on the REACH project has any. It's just kind of been added to our sort of daily repertoire, and we have to try and fit it in amongst all the other things that we're doing. Not one of us is dedicated to the REACH, and we all have various other projects that we're working on. I think to some degree we all manage our own diaries, so it's about trying to fit it in and spin plates and drop whichever is the least priority at the time, unfortunately. Jo is the QI expert, so I'll hand over to her in terms of the QI question.
Yes, so I think in terms of the QI question, it has absolutely been QI by stealth in this space, and I think that has been the right thing for here, because it's an ED environment, it's very fast paced, very adrenaline fueled, and there isn't a lot of time for people to do a lot of QI training, go on all of our courses and everything. So it has been very much using the right tools in the right spaces, and people then realise that actually that's a really useful thing that we've just done, and that didn't take that long to do. So how did you do that? And people have then started to use the tools in different areas, which has been great in terms of spreading that sort of methodology throughout the department and the services that this project has touched. And a consequence of that is that now our GM here, who was really not very interested really in all of the sort of methodology that went behind it, because she was very busy, is now going to become hopefully involved in the QI faculty, and is going to be part of our sort of our cohort of people who can talk about projects that have used the methodology successfully in the organisation. So it's building capability and capacity, but not overtly. It definitely wasn't something that we came in and said, right, this is going to be a QI project. This is all the tools. This is what we're going to do next, because that wouldn't have landed well. And actually probably wasn't, the team wouldn't have been ready for that at the time. There was no background knowledge of QI or anything to build on. But I think it's laid a nice foundation for future, change methodologies to be approached in a QI fashion.
Thanks, Jo. QI by stealth. I'd love a whole session on that. We do have to finish and wrap up soon, but I do want to hear from the final two groups and invite someone from each group to ask their questions or reflections. So the group that had Pete, Rachel, and I can't read my handwriting, Scott.
You going, Pete, or shall I? Go on, you go, Pete.
Yeah, I'll go. Just it's really interesting listening to everyone talk about patients, because I'm very much approaching it from the opposite side of things. So I've been using a wheelchair for 16 years, and I've set up my own community interest company supporting other wheelchair users as well. I've been working on this full time since January, and I've been trying to basically figure out where this sits within the NHS. It's got really positive outcomes. I think there's a lot of big impact on patient lives, and with social value as well. I think it's essentially a big cost saver for the NHS, but there's no pathway out there at the moment that looks at innovation from lived experience, and I think that could hold a lot of benefits for bringing kind of new ideas from a different perspective to the table. So it's very much it's great to hear so many people talking about driving ideas forward and making sure that patients are involved in the conversation, but how is that pathway in from lived experience being supported?
Thanks, Pete. And the final group, Hader, Lisa, Rhiannon, Rob and Sally. One of you want to?
So I think I got volunteered from this group. A lot of the discussions that we had and the questions that we had, I think have already been addressed from some of the other groups. But the one that we had that I don't think has been touched on is just around the role of the sponsors or funders of partnerships. So it's the kind of we talk about the kind of the psychological safety and having the common goals within the partnership, but how is that supported outside of the partnership in terms of if there are external organizations or sponsors, how do they nurture the partnerships, or at least if not nurture them, stay out of the way? I'm curious what the experience of the panel has been in relation to that.
Thank you. Quick responses then, just 1 minute. Alan.
So very quickly, we've had to work really hard with our trust, so the trust that I work for, to keep them informed, to try and get them to embrace the project and to understand they're supportive of the objectives and the principles, but we just have to keep them on board and regularly remind them. But in terms of an external organisation, I don't think there has been. The Health Foundation have been incredibly supportive, a great organisation to work with, and they've given us partner organisations like National Voices who have helped understand the process that we're putting into this project.
Jo.
I think from our perspective, our sort of external stakeholder partners are our system colleagues, sort of was the CCG and then it's changed to be the ICS, ICB, as our main sort of external bodies that we need to keep informed of what's going on. And it's a slightly tricky space sometimes to work out the governance in those areas and who's reported to who and who needs what and who has the final say, if it's the trust or if it's the ICB. It's a slightly forming system, I guess, which is tricky to navigate, I think, in a project space, and that's something we are still learning and growing within. I think everybody's learning at the same time in that space, and it would be really useful to get reflections from others who are also trying to affect change across systems in a transforming system as to what those learnings are. And I wonder if that's a future opportunity for one of these, Jo, to share the reflections in that space.
Thank you. Rachel, did you want to have the final word, then I hand back to Zarina?
Oh, I feel very privileged now. I was just going to pick up on the bit of how to support people to get involved. And there's no one way fits all in that one, is there? We do offer reimbursement for people to get involved in the project. And that's something that we as a charity think about more broadly, but it's not just about that. And we are looking at ways of engaging people and reaching out into communities and getting a wide range of views involved in the project. What we've been really key is trying to get a representative range of people that are living with IBD in Sheffield involved in the project, and really using networks and ways to reach out to them. But it's not straightforward. It's a work in progress, but really important.
Thank you, Zarina.
Great, thank you, Jo, and all of the case studies. I'm really conscious of time and that we could have spent so much longer asking questions and hearing from you all. So just want to thank you on behalf of everyone here. If I can just keep you for 2 more minutes, I'd just like you to do a little checkout reflective activity. So in the chat, I'd like you to pop in what stood out for you from this session, any light bulb moments. Yeah, important to spend time developing relationships and establishing a shared purpose. Yeah. Importance of psychological safety. Okay, to be wrong together. Yeah. Any other reflections or light bulb moments? Good stakeholder mapping. Session right at the beginning, establishing the power distribution early, and balancing protected time. Great. And then the final reflection question is just, what are the further conversations that we need to have about this? And just a reminder as well on this point, if any of you are coming to the hub, in-person hub events next week in Leeds and Bristol, there is an open space question framed around what are the most important conversations we need to be having about collaborative improvement that will help you to progress your work. So have a think about any further conversations you want to have and you want to hold as well. Quite a few reflections coming through. Make time for partnership working. Yeah. Great. So yeah, that brings us to the end of the session today. I know there's a few reflections still coming through. Sarah or Joanna, they're just going to pop up a quick evaluation poll. Just as we said before, it's really helpful to understand what you liked or didn't like about the session so we can learn and improve in the future. So if you're able to answer that, that would be great. And if you'd like to, you can find the partnership guide online and on our website. And you'll also find a whole host of other resources that will support you to collaborate across boundaries, including our Skills for Collaborative Change map and user guide as well. So always keen to hear what you think and how you might be amending our resources or using them in practice. Nearly everyone's responded to the evaluation poll. I'll give 1 more minute. I'm still seeing a few reflections come through on the chat as well. Thanks, Alan. Yes, perhaps other nurses, allied health professionals would like to join Q or raise awareness. Goes without saying, please do raise awareness of Q with your networks. That's really great to hear. Thank you. Great. I think most people have completed the evaluation poll. If you've got any other questions or reflections that you want to pop in the chat, please do. But otherwise, just thank you for your energy and participation, especially after lunch today. And just a reminder, we've got the final plenary session of the Q event, which will be happening in 8 minutes at 3:25. So have a quick break to stretch your legs, grab a cup of tea, and then you can head back to the event platform. Thank you for having us and joining us rather. Thank you.